Thank you, Dr. Gupta. And firstly, I take this opportunity to thank all of you for being here. And actually, a couple of years after we started, Sir, Dr. Palajani gave me the responsibility that, we should sum up the conference. So I was just thinking, why sir has given me the responsibility. So he made sure that, I have to stay in the hall from the beginning to the end and make some notes. And well, I think that really helped me. And I've been continuing that tradition for last couple of years. And now actually I'm very keen that from next year, Akshay starts doing this in place of me. Actually, that will be a so Akshay, be ready. So last in the last 2 days we had a lot of good lectures, and I'll just give a very brief summary session-wise. We begin with the first session, which was on the guidelines, and there were 3 guidelines discussed: the guidelines of on hypertension, coronary artery disease, and acute coronary syndromes. Hetan began with the guidelines on hypertension, and the couple of messages, which come from her talk was, one was the blood pressure levels, which you should lower down, and they keep changing from guidelines to guidelines. And you have to individualize the goals in terms of the reduction of the levels, looking to many factors, 130 by 80, 140 by 90. Those figures are important. Another important thing actually to take from these guidelines is that there are now a lot of electronic devices. Apple Watch, very commonly, multiple electronic devices for measuring blood pressure. Now these devices are good for creating awareness, but they are not the ones which are helpful in the treatment. Ultimately, the treatment should be guided by the physician. The combination of the drugs is the most important thing, and most of the times we require combination. One drug, 2 drugs, or 3 drugs, and calcium channel blockers still remain the one of the most effective drugs, either alone or in combination with other drugs for controlling the blood pressure. Those patients who become unresponsive to multiple drugs, the renal denervation therapy is now come in the guidelines, and this should be used where facilities are available in the cases where it can be applicable. Yesterday there was a question during the Dr. Hetan's talk, after the Hetan's talk, which could not be answered, and I thought I'll take this opportunity. And the question was that if the systolic pressure is 140, 140, and the diastolic pressure has come down, how do we titrate? There is a concept called as a J curve, and this J curve has been studied in many studies, including the INVEST trial. And the J curve hypothesis says that if a patient is elderly or the patient has got a coronary artery disease, then reducing the lower pressure below 70 and bringing it in the range of 70 to 60 can increase the cardiovascular events. So I think this J-point hypothesis should be kept in mind, particularly when we are dealing with systolic hypertension in the elderly population. Then Akshay dealt with the guidelines on chronic coronary artery disease. You all must be aware that the European Society of Cardiology uses the terminology chronic coronary syndromes, and now ACC has started using the coronary artery disease. He described the 5 groups which are included in chronic coronary artery disease. And a couple of points I think to take from his talk. One is about the use of single antiplatelet, dual antiplatelet, and when to add the NOAC or anticoagulation. And what Akshay told us was that we should look at the data of COMPASS trial, and those patients who have coronary artery disease in addition to coronary artery disease, if they are having a polyvascular disease, these are some of the patients where you should consider adding the anticoagulation. I think 2 important things which I thought was to bring to this. One was the use of beta blockers in those patients where the ejection fraction is normal. beta blockers are not as beneficial as they are in patients with reduced ejection fraction. So when you are using, many times we use beta blockers absolutely in every patient of chronic coronary artery disease. If there is angina, you want to use for its relief, it's fine. But a blanket use of beta blockers in all patients with all range of EF may not be warranted. Similarly, he also gave a warning about use of ivabradine in those patients where there is a normal ejection fraction. He gave another important point, and which I thought is important to emphasize, is about the use of statins in women. And there is now some data emerging that if there is a pressing indication, you can use statins in pregnant women after the first trimester. He sort of very precisely classified the indications of PCI versus CABG. And then there was a guideline talk by Dr. Suresh Vijjan on acute coronary syndrome. And from Suresh's talk, one was these guidelines include unstable angina, non-ST elevation, and ST elevation acute coronary syndrome. Apart from the history, one of the most important thing is do an ECG within 10 minutes of patient's presentation. If there is a ST segment elevation, this patient should go straight to cath lab if there are facilities available. If cath lab facilities are not available and he cannot be sent to cath lab, in next 120 minutes, thrombolize the patient. If there is a normal ECG or ST segment depression, your approach should be different. And then of course there was all the usual talks about using the antiplatelets, anticoagulation. Another important thing I think Suresh came out was, which possibly has not been there in the previous guidelines, was about using permanent pacemaker in some patients of acute myocardial infarction. And he told that permanent pacemaker in those patients, is possibly those with the interval MI, it should be done within the first 5 days. So that is a possibly a little gray area. And of course, he also talked about PCI in multivessel disease and the increasing role of OCT, which is coming. The session 2 was on lipids, and it began with Bhavesh talking about the traditional drugs which we all have available, statins, bempedoic acid, and ezetimibe. 2-3 messages from Bhavesh talks. One was what should be the LDL levels which can be brought down. And he told that the normal LDL levels in neonates have been 20 plus minus 10. That's been the levels in neonates. Actually, when we read this statin literature, elephants have a cholesterol level of 10 milligram, and they don't have any atherosclerosis. So many times the people who talk about the statins and who are the lipidologists, they talk about bringing these LDL levels to as low as 10. Of course, the debates are happening and the levels are coming low and low. But I think at this point, what we know is that rosuvastatin can achieve a reduction of 50%, 55%. Various guidelines are telling 55, you bring LDL, 70. Our Indian guidelines are talking of further 30. Ezetimibe and bempedoic acid give helping hand to statins for reducing the LDL levels. Samir spoke about PCSK9 inhibitors, and he talked about the newer Glegov trial, about the Fourier trial, and the extended data of the Fourier trial. And I think 3 important points. PCSK9 inhibitors cause plaque stabilization, they reduce the LDL, and they also reduce the LPL levels. And PCSK9 inhibitors have already been available, and they are in use. There is now data with PCSK9 inhibitors, even in acute coronary syndrome, where they can help in plaque stabilization. With PCSK9 inhibitors, in contrast to statin, there is still less data in terms of hard endpoint reduction, but PCSK9 inhibitors are now available for clinical use. Ajit spoke about the new molecule in inclisiran, which is now available, and this is being touted as a vaccine for coronary artery disease. And Ajit spoke about the Orion trials, which I think all the residents and every one of us should read. And inclisiran also has a capability not only of reducing LDL but also LP little a. Again, the outcome data is not there with inclisiran at this point. You have to give 2 initial doses, and after that it should be every 6 monthly dose. It is now available in our city and our country. Then the next session was about interventions. Dr. Bhagwat spoke about various techniques of bifurcation stenting and how the results in bifurcation has improved, the increasing use of imaging in bifurcation and the multiple techniques. He also talked about his own technique, which he has mastered. Ajit spoke about the LMCA, and I think left main coronary artery PCI is one area which has really undergone extremely good innovations with good data. And for ostial and shaft, ostial and shaft of the left main coronary artery stenosis, there is a lot of data where equality or even superiority of left main coronary artery stenosis vis-a-vis bypass, there is data. However, the bifurcation left main stenosis is an area where I think one should choose the cases. Complicated is the case, surgery as an age, and complicated bifurcation patients are the one where there is a lot of use of imaging. You should do FFR imaging and then take this patient. So if there is a complex left main along with bifurcation, this is one area where still coronary artery bypass graft surgery may be better. If you decide to do these cases, they should be imaging guided. The next session was then imaging trials, and this was a talk by Shantanu. And there were some new trials which have come in the imaging area, the Illumine trial and the October trial. So far we had a lot of earlier trials, and these earlier trials told us that, by doing intravascular ultrasound and OCT, you can do the cases. We understood a lot about atherosclerosis. But now these new trials are coming, which are giving us a good amount of data to tell that use of OCT and intravascular ultrasound can better the long-term prognosis. And particularly the October trial, the Illumine trial actually failed to give the benefits in terms of outcome because of, and I think one of the reasons was told was that there was COVID, and because of the COVID, the follow-up was not good. But these two trials are extremely good new trials, and those who are interested in this area should look at it. The next session was on the imaging, and I think I personally liked the talk which Jhala gave as one of the best yesterday, and he spoke about the assessment of thick ventricle by echocardiography. And I think what one should learn from Jhala's talk is that if you do an extremely good echocardiography along with use of speckle tracking, use of Doppler, you can diagnose several causes of thick ventricles, the commonest being systemic hypertension, left ventricular volume overload, and then uncommon causes like amyloidosis, hypertrophic cardiomyopathy, and sarcoidosis. He showed various extremely nice examples, and I'm sure that when we train our DM students, we should train them to do good echos. And the information which Jhala gave was looking like that, you are very close to giving a good competition to MRI. I'm not telling that MRI should not be done, but I think we can derive an extremely good data from two-dimensional echocardiography, which is available to everybody. And then there was a topic of viability, which I dealt with. Just two lines from that talk. Viability assessment, we all have done for last 40 years by various modalities, dobutamine echo, by SPECT, by FDG PET, and by cardiac MRI. different things you see when you are trying to look at the viability, whether you want to look at the scar, you want to look at the cell integrity, the glucose metabolism. In today's date, the debate about which modality is better, which modality is not, has narrowed down, and there is a sort of more consensus that MRI may be the most important modality. But what bigger controversy has now emerged is that the viability, the presence of viability necessarily doesn't mean that there will be a good prognosis. And on the other hand, the absence of viability doesn't mean that the guy is doomed. And the two trials which I discussed, and I named those trials as disruptive trials, disrupting our concept of viability, are a STITCH trial and a REVIVE trial. And I think those who are interested should read these trials. The STITCH trial is the imaging data of the original STITCH trial. Then our next session yesterday was, and then Minoka talk by Dr. Burkule. He talked about myocardial infarction with normal coronary arteries and how we should assess these cases. He gave the various examples of how echocardiography you should use, how also you should analyze the coronary angiograms of these patients, use the MRI, use the PET scan and all that. And in addition to what Dr. Burkule talked here, I just want to mention one point. There are now many laboratories which are called as coronary functional angiography laboratories. Those patients where their coronary artery turn out to be normal, most of the times when epicardial coronary arteries are normal, most of us will say, well, this patient doesn't have anything, or we will label them loosely as having microvascular angina or syndrome X or what. For them, actually, there are a lot of protocols, a lot of studies which you should do in these patients other than the epicardial spasm study. So it's a huge new area. 2023 and 22, JSCC has multiple articles, and postgraduates should take interest in this. We began this morning with talks on some of the new pharmacological agents. Dr. Kane spoke about vericiguat, a additional drug, not a drug which really changes the hard endpoint, but it changes recurrent hospitalization, is vericiguat, and he gave the guidelines in which patients you should use. Then there were some weight-reducing drugs about which Rajesh spoke, and one of the important, and when we think of using the weight-reducing drugs, and they are used quite a lot by our diabetologist colleagues, and particularly Rebellious orally is extremely commonly used by the diabetologists and even by physicians, and this looks a good drug. One should know that these drugs have safety issues, the minor ones being GI issues, but the important ones being association of cancer with some of them. That was the messages from Rajesh talks. And then Praveen Kulkarni spoke extremely nicely about immune check inhibitors. A couple of years back in one of our academic conference, we introduced the topic of cardiac oncology, and we got one of the experts from Cleveland Clinic who spoke on cardio-oncology. That time this specialty was just developing. But we see now that a lot of patients with advanced cancers, advanced metastasis, immune check inhibitors are used. And these immune check inhibitors have certain cardiovascular side effects, and one of them is the immune check myocarditis. And this is an entity which is uncommon or rare, but has got a very severe, but can have a very adverse outcome. So its diagnosis should be kept in mind, doing the ECGs and doing troponin before every dose of immune check inhibitors. Then our next session was on the structural heart disease, and I think we had two excellent talks, and I must convey my appreciation and thanks to Sai Satish, who was very kind to come. And Sai Satish showed us some of the exciting examples of how interventional techniques can be used for diagnosing, for treating patients of secondary mitral regurgitation, secondary tricuspid regurgitation, and the application of mitra clip in selected cases of primary mitral regurgitation. This is an exciting field, and experts can give rise to good results. Also, there was talk by Anmol on TAVR, and he did tell us that how TAVR field has evolved now from high-risk patient to mid-risk patient to low-risk patients, and TAVR actually can be applied to a large number of patients. Then there was a session on electrophysiology, and Ashish and Amit, Dr. Amit Vora and Ashish Nabar, they spoke on CRT and alternate site pacings. I'll club my remarks for both their talks. CRT is now extremely established procedure with its benefits, and we all know the indications for CRT. Amit introduced a new concept or new terminology for us to understand, and what he told was now we are moving towards what is called as a cardiac physiological pacing. Those persons where the ejection fraction is below 30 to 35%, CRTP is an established procedure. But in ejection fraction groups between 35 to 50%, there is a concept of cardiac physiological pacing which is evolving. There are three areas. There can be alternate site pacings which are required. The alternate site can be a His bundle pacing. It can be a pacing which can be in mid-septal location, and also pacing which is called as a left bundle branch block pacing, or LBB area optimizing pacing. So these are refinements on the CRT, and I think the electrophysiology should choose what can give the patient the best result and the best narrow QRS complex. And we had talk by Dr. Vanita, and again Vanita was very kind to come from Delhi and enlighten us, and she spoke about the leadless pacemaker technology which has been available for last couple of years. I think two important things which Vanita told right in the beginning was leadless technology is not for every patient. Second thing is leadless technology is not as physiological as the other modalities, like we are talking of CRT or cardiac physiological pacing. The main use of leadless pacemakers in our country has been for the infected pacemakers, and also when there is a problem of the venous excesses, I think we have been using the leadless technology. In leadless technology also, the placement of the pacemaker is an art, you know, how you tug the device. And now, very soon, we may have the newer techniques, and we may have a dual leadless pacemakers, dual chambered leadless pacemakers. And then there was the interactive session with the cardiac surgeons, which all of you have heard, and it was extremely exciting. There was futuristic talk on AI by Dr. Ponde, and I will only say that I'm really lucky that we were born before, so that we could have good students like Dr. Ponde. Now, if we were born in the AI era, I think we could have just seen some machines and machines surrounding us, and not good friends and good colleagues like Dr. Ponde, Amit, and many of you. And of course, the final talk was again by Dr. Jhala, and what he tried to tell us that guideline-directed medical therapy is important, and in relation to the heart failure, you should not start even when the ejection fraction starts improving. You should not abruptly reduce medication, and you should sort of assess these cases in the light of overall information which we are having, and the improvement ejection fraction is not the end of the disease. and we should not suddenly stop the GDMT, and we should continue it. We may sort of downsize it if on case-to-case basis. I think that will be my summary, and will not like to bore you people more. And thank you very much for your patience listening.
I think just 2 minutes I'll take of yours, and I would like to thank the Faculty Council of Academy of Cardiology. It was a good teamwork to work with Dr. Satyavan Sharma, Dr. Milind Phadke, and the blessings of Dr. Pairajani and friends like Dr. Akshay, Bhavesh, Dr. Bhagwat, Ajit Desai, and Dr. Niyar and other friends to have this meeting. I thank all the delegates for, I think, as compared to the previous few meetings, the attendance was too good, and I thank all the delegates. And the last and not the least, I thank all the pharma industry people for supporting us and getting this event successful. And thank to Vama Events and the Hotel Taj and Marriott Executive Apartments for their hospitality. Once again, thank you very much and enjoy the lunch. And look forward to see you in AOC 2025. Thank you.